Hello, everyone. So first, just I want to thank the organizers and Dr. Carraro for giving me the opportunity to present our work. So my presentation will be about cholesterol perturbations in the context of Duchenne muscular dystrophy. So to start, I don't think there's need to reintroduce Duchenne after Professor Sweeney's lecture this morning. So it's X-linked recessive muscular dystrophy with early onset. Which would lead eventually to a premature death. So ever since the dystrophin gene was characterized as the cause of DMD, the common theory behind the pathophysiology of Duchenne was of a mechanical problem. So we have dystrophin that's doing the link between the muscle fibers and the extracellular matrix. And when we lose dystrophin, we will lose this link, and this would lead eventually damage after decontraction, and would lead to a progressive muscle wasting. So that is when we look at the pure mechanical problem in Duchenne muscular dystrophy. But DMD is also, there's a secondary pathology that's happening in the muscle, and it's we can see many metabolic perturbations. For instance, we can see fibrosis, inflammation, dysregulation of mitochondria, and mainly also lipid accumulation. And that's one of the main things we are interested in. So the reason we are interested in lipid metabolism in the context of Duchenne, it was because a few years ago we did a microRNA screening on a cohort of DMD patients. And one of the things that stood out in this screening and analysis was the dysregulation of the fatty acid synthesis pathway and the mevalonate and cholesterol pathway. And when we look at biopsies from DMD patients, we can see cholesterol accumulation within the muscle fibers. So we can check that with Philippine staining, for instance, here, and by measuring the total cholesterol in the dystrophic muscle. So this was also validated in the MDX mouse model, which is the most common mouse model in Duchenne. So we saw an accumulation of cholesterol in the dystrophic muscle. And when we treat with simvastatin, which is one of the most common lowering cholesterol drugs, we are able to reduce this cholesterol charge in the muscle fibers and to restore some of the dystrophic parameters. So we reduce fibrosis and we reduce some of the serum biomarkers. So, but the idea is that cholesterol metabolism is not that simple, actually. It's a bit more complicated than just blocking with simvastatin, for instance, because it's the combined outcome of the uptake of cholesterol, so what we are taking with our diet, the synthesis of cholesterol, so that was what we blocked with simvastatin, for instance, and the efflux of cholesterol. It means the cholesterol that's getting back from the peripheral tissues up to the liver. And the muscle plays a very important role in this process. And the thing is that when we look at MDX mouse model or any muscular dystrophy mouse model, the diet does not really represent the eating habits of human or patient, because unfortunately we do not eat as good as our mice. So one common thing to do is to, in the context of studying lipid metabolism, is putting mice on what we call a Western diet, which is a high-fat diet. And so that was exactly what we did. We took very young wild-type mice and MDX mice. We put them on a high-fat diet, which was supplemented with additional cholesterol, and we checked after 4 weeks different parameters. So first thing we checked was lipid accumulation in the liver, which is the point of entry. So we can see lipid accumulation in both the wild-type liver and the MDX one. So there's no difference here. But when we go to the muscle here, what we found some interesting stuff. So first we looked at fibrosis with a red cyrus staining here. And what we saw that there was an increase of fibrosis for mice that were fed with the high cholesterol diet. So we checked, for example, here in the diaphragm and the gastrocnemius, which are the most fibrotic muscles in this MDX model. And we saw an increase only in MDX mice. And then we checked also for cholesterol accumulation in the muscle. And what we see, so this is what we knew before, when we compare just wild type to MDX, we have an increase of cholesterol. And then with the high fat diet for wild type, we see some cholesterol going into the muscle. and even more, of course, in the MDX. So we saw that by quantification of Philippine, but also by measuring the free cholesterol in the muscle. So we can see the effect of the diet of this cholesterol going into the muscle. So the question is, where is this cholesterol going exactly in the muscle fiber? So if we look a bit on, if we take a simplified version of cholesterol trafficking, so when cholesterol goes into the cells, it binds first to the LDL receptor. So LDL cholesterol is a bit known as the bad cholesterol, which is not entirely true. But so when cholesterol enters the cell through endocytosis, it will go first through the endolysosomal system. So that pushed us to check a bit more the endolysosomal system and what's happening there. And in fact, what we found was that there was a specific accumulation of cholesterol within the lysosomal lumen. So what we checked here was the Philippine staining, so for cholesterol with LAMP2, which is a common marker for lysosome. And we can see a very high colocalization between cholesterol and lysosome, but only in the MDX. So for instance, in the wild type mice that were fed with the high cholesterol, there is cholesterol accumulation in some fibers, but it's not going into the lysosome. And then we checked a bit some of the lysosome parameters in the muscle. So for instance, here we checked for LAMP2, which helps quantify the lysosome in the muscle. And we can see a clear increase of lysosome, so of lysosome number, but also of lysosome size, as we can see by immunostaining. So there's an upregulation of lysosome within the dystrophic muscle. And if we check for the transcription factor that regulates the whole lysosomal biogenesis, which is TFEB, we can see a translocation of this transcription factor into the nuclei in the MDX mice. So there's a clear activation of lysosomal biogenesis in the dystrophic muscle. So our approach that we have been working on for some years now in the lab is one of combined therapy. So the idea, Dr. Sweeney, for instance, this morning presented the microdystrophin approach, which aims to restore the dystrophin expression with a shortened version of dystrophin, so the microdystrophin. But in our approach, what we aim to do is to combine this gene therapy approach with a metabolic correction. So by tackling some of the major metabolic problems that we see in the dystrophic muscle. And for us, the most interesting one, or the one that we have been working on recently, were the lipid and cholesterol metabolism and the lysosomal function, which are closely related. So in our first try in this article that was published last year, we tried simvastatin in a combined therapy setup, because simvastatin was reported a few years back to have a beneficial effect in DMD. So in our results, we got reduced fibrosis, but unfortunately, there was an increase of muscle necrosis with simvastatin, which is one of the often adverse effect of statin treatment, which is the statin myopathy. So it was a bit counterintuitive to use it in the context of a muscular dystrophy. So what we are doing now, so now we are trying to screen for drugs that will clear cholesterol out of the lysosomal lumen. And so to do that, we have a bit, we had to develop an in vitro readout to screen for drugs. And what we do is quite simply is to block one cholesterol transporter, which exists on the lysosome, on the membrane of the lysosome. So it's called the Newman-Pick receptor, which is involved in other lysosomal storage disease. And what happens is that when we block this receptor, we have a cholesterol accumulation in the lysosomal lumen. And this would allow us to screen for cholesterol clearing drugs from the endolysosomal system. So the setup is quite easy. We plate our myoblasts, or we differentiate them into myotubes, and then we block this NPC1 with a pharmacological inhibitor. We put out drugs, and then we load the cells with a fluorescent analog of cholesterol. So in this case, it was called NBD cholesterol. And then what we can calculate by this is the cholesterol efflux. So it means the cholesterol that's getting out of the cells. So we do that by simply measuring the ratio between the fluorescence in the media and the total fluorescence between media and cell lysates. But we can also check for cholesterol charge with normal fluorescence imaging. So for example, here we can see the cholesterol efflux rate in normal untreated myoblasts. When we block NPC1, we see a decrease of this efflux rate, so cholesterol is getting stuck into the cells, and then we screen for some drugs that will help increase this efflux rate, so help alleviate the cholesterol trafficking within the dystrophic, within the cell, sorry. And when we check also on differentiated myotubes with confocal imaging, we can see the cholesterol charge in individual myotubes. So we can see some drugs are better than the others, for instance. So the main takeaway from my presentation, what I wanted to show was that first, free cholesterol is accumulated specifically in the lysosomal lumen in the dystrophic muscle. The cholesterol dysregulation that we see in Duchenne and some other muscular dystrophies is correlated with closely with lysosomal trafficking. And so there's need to identify new drugs that will help clear cholesterol out of the endolysosomal lumen and improve the endolysosomal trafficking. So to finish, I just want to thank my mentor, David Israeli, the PI of our lab, Isabelle Richard, all the Geneton platforms, and you for your time. And I would be happy to take your questions if you have any.
Questions?
Do you know by any chance what are the mechanisms that bring this cholesterol accumulation into the cell?
First, what we identified in the first paper that was published a few years ago, there was a activation of the SRAB pathway. So SRAB is what's responsible for the endogenous synthesis of cholesterol. So that was activated, and that would lead to two things. So it would lead to a production of cholesterol in the cell, and it would lead to a high expression of LDL receptor. So it will have a bigger uptake of cholesterol from the outside. So that is one of the main reasons that cholesterol is getting stuck in the fiber.